that queasy, metallic first week on a new diabetes tablet, and the only guidance in the leaflet was, take with food. I'm Annabelle Cross. Welcome to MedHeads. Over 150 million people take metformin right now. It costs almost nothing, and it's been in medicine since 1957. Most people know what it does, but very few know how it does it, or what it's been quietly doing on the side. Today we're going to cover the actual mechanism, a side effect that can mimic the disease it's treating, and a large clinical trial that is using metformin to ask a much bigger question than blood sugar. Let's start with what metformin isn't. It isn't insulin. It doesn't nudge your pancreas into releasing more. It goes to your liver, and it works by activating a protein called AMPK, AMP activated protein kinase, which is essentially the cell's built-in fuel gauge. When AMPK flips on, it reads the situation as low energy and tells the cell to tighten its belt. In liver cells, that means dialing back gluconeogenesis, the process where your liver manufactures new sugar from protein and fat and pours it into your bloodstream. So blood glucose drops, not because you have more insulin, but because your liver stopped flooding the system in the first place. The gut side effects, the nausea, the loose mornings, the metallic taste, happen partly because metformin also changes the gut bacteria and the gut lining in those first weeks. Most of it settles once your system adjusts. Your blood sugar didn't fall because of extra insulin. Your liver just stopped making so much. But the liver isn't the only organ that noticed, and this is where the prescription story gets interesting. Here's the part that doesn't usually make the prescription leaflet. Metformin interferes with calcium-dependent receptors in the small intestine. And one of the knock-on effects is that it impairs how well your gut absorbs vitamin B12. Not dramatically at first, a slow, quiet drain over years. Studies tracking long-term metformin users have found rates of B12 deficiency anywhere from around 10% to over 30%. And a large 2025 study from the All of Us research program, looking at nearly 15,000 adults, found long-term users had a 67% higher likelihood of B12 deficiency than non-users. Here's why that matters so much. Low B12 causes peripheral neuropathy, tingling, numbness, weakness in the hands and feet, which is also one of the most recognizable complications of diabetes itself. So some people have managed those symptoms for years as diabetic nerve damage, without anyone checking whether metformin was lending a hand. The fix is simple, a blood test, once a year. But it's not yet universally built into guidelines everywhere. The neuropathy wasn't only from the diabetes. Sometimes the medication was pulling in the same direction. Now here's where the story takes a turn that nobody expected. In 2014, a large UK study made a striking observation. People with type 2 diabetes who were taking metformin were, in shorter-term analyses, surviving longer than comparable diabetics who weren't on the drug. And in some data, they were even outperforming matched healthy adults without diabetes at all. A drug treating a serious condition seemed, in the short term, to be beating not having the condition. Subsequent analyses with longer follow-up complicated the picture, as observational data tends to. But the observation was striking enough, and the mechanism specific enough, that it seeded a serious idea. That mechanism again is AMPK activation. When you switch the cell into fuel-saving mode, you also switch on autophagy, the body's cellular housekeeping system, where damaged proteins and worn-out components get broken down and recycled. Autophagy slows as we age. Metformin, the thinking goes, might be asking cells to keep doing it longer, which is what the TAME trial is testing. Targeting aging with metformin, an NIH-backed randomized controlled trial across 14 US sites, enrolling 3,000 people aged 65 to 79 without diabetes, measuring whether metformin can delay the onset of heart disease, cancer, cognitive decline, and physical frailty, together, as a cluster, not one at a time. Results aren't in. This is live science. But the question is now serious enough to have attracted serious funding, and that tells you something about where the evidence points. Metformin might not just be managing blood sugar, it might be asking cells to tidy up a little more carefully. None of which means metformin is the only option. A class called SGLT2 inhibitors, drugs like empagliflozin, work by making your kidneys flush excess glucose out in urine, and they carry separate proven benefits for the heart and kidneys. GLP-1 receptor agonists, semaglutide, tirzepatide, lower blood sugar, drive significant weight loss and have shown meaningful cardiovascular benefits in their own right. And for some people, the most powerful intervention isn't a drug at all. Diet changes, sustained exercise, and meaningful weight loss can put type 2 diabetes into clinical remission, not just managed, but gone from the labs, in a proportion of people significant enough to sit in international guidelines now. Metformin keeps its first-line status for good reasons. Cheap, safe, 7 decades of data behind it. The landscape it sits in, though, is moving fast. If you're on metformin long-term, it's worth asking your doctor about a B12 check. One blood test. Knowing is always better than guessing. Have you been on metformin or switched to something else? What surprised you? Drop your experience in the comments below, especially if a side effect caught you off guard. And if you want more evidence-first breakdowns like this one, subscribe. There's a lot more coming.